Welcome to COVID Chats and Facts with your host, Senior Diversity Specialist, Amber Booth-McCoy.
Hello. Thank you so much for joining us today for this week's COVID Chats and Facts. As always, my name is Amber Booth-McCoy, your host. And today we are talking about how sick are we? So as always, today's segment is sponsored by the UAMS Division for Diversity, Equity, and Inclusion. And like normal, I have an amazing guest with us today. We have the incomparable, the amazing Assistant Dean of Student Affairs in the UAMS College of Pharmacy and President of AMDPA, Dr. Lanita White. How are you today, Dr. White?
I am well. Thank you so much. Good morning.
Good morning. So let's jump right in and talk about how sick are we. We're talking about the tracking, tracing, and reporting of COVID in the Black community. So what are the numbers saying, Dr. White? Like, how sick are we?
Well, that's a complicated question, right? We are sick, and the numbers are telling us that everyone's affected. Communities of color, males, females, even children. We know our elderly, that huge chunk of people that are between the 20 to 64 age range. Everyone is affected. But I think in particular, we have to look at the aggregate numbers, right? So in Arkansas in particular, we are sitting today at 3,281 number cases of COVID-19. And as you know, those numbers change daily. There are patients that are recovering. There are new patients that are sick. But the thing that I always look at is the deaths. How many people are dying from this disease? And right now in Arkansas, we're at 61 deaths. And while any death grieves me greatly, it's a little bit encouraging to see where we are with our number of deaths, because the projections were that they were going to be much greater. What I'll tell you, though, is in the African-American community, so far of those deaths, 36% of those deaths are in the African-American community. So we know the population, the African-American population of Little Rock, even just in the county, much less the state, is not 36%. So that feels very overrepresented. And I think that's for a couple of reasons. I think one of the reasons is where the largest number of COVID cases are. So they are in counties that have a large African-American population. And the other thing I think is what we call ground zero in Arkansas, so that Jefferson County area. We have a lot of African-American people in Jefferson County. And so I think that the numbers are somewhat skewed, but they're still very concerning in our community. And so we are seeing a significant number of African Americans affected by COVID-19. And I think that's for a couple reasons, right? So we always think about, why are these numbers different in the African American community? Or why are we at 36% in the African American community when we're not that percentage of the population of Arkansas? And I think several things happened. I think that early on, there were, a lot of funny memes on social media and a lot of, if you did this, you can't get COVID. And I think we had our guard down in the very beginning. I think
because we were talking about not being able to get it, right? Being immune to
absolutely,
and things like that.
Absolutely. And of course, as Black people, we have lived through a lot, right? But our immune system is just like everyone else's. Our propensity for disease is just like everyone else's, and in some cases greater than other people. And so I think our guard was down initially, and we had to reset, if you will, and really take this disease seriously.
And I think even with that resetting, if you will, even if we move past the us, acknowledging that we can get it and things like that, the demographics or the characteristics of who we thought were vulnerable even kind of expanded as well. At first it was if you have underlying health conditions, and then if you are of a certain age and things like that. So, of course, I think we may have always been concerned about Big Mama and, all that if as the Surgeon General said. But then there started to be younger people passing away as well from this disease that maybe did not have these same underlying conditions. So who we thought to be the most vulnerable, at least for me, expanded and made me even look at the disease a little differently. I think that may have had a lot to do with even, I guess, how we shifted the way we look at the disease in the Black community.
I think that's such an interesting point to explore. So when we think about the vulnerable populations that we typically think of first, elderly and children, right? And so we think of our children because we don't want our babies affected. We want them to be safe and protected. And what we found is that while there have been a few children who have died as a result of COVID-19, what we know from children is that they are more so carriers, right? And so they may not necessarily display the signs and symptoms. They may not get hospitalized, or they may not even know that they have it, but they can certainly spread it. And there's a risk of them spreading it to our other really vulnerable population that we think about in the beginning, which is the elderly. And so with elderly people, the way that we thought it would spread has not been the case, because many elderly people stayed inside when we asked them to. And they didn't necessarily go out and be amongst people where they could contract the virus. But what happens with elderly people... Say it again?
I'll say if I may. The elderly stayed in, and I also want to make sure that we acknowledge that every commercial and all of that we have seen, and as a millennial, I would like to say that we are grown. Millennials do not take spring breaks. Millennials have real jobs. So millennials have kids. I have a 14 and 16-year-old. So millennials were not out. Millennials were old enough to take this thing seriously, and it was even the younger, the generation under that, Generation Z and maybe younger. And then even as you were saying, the children, there were carriers that I decided to call all children Typhoid Mary, because they were going around not purposefully infecting people like Typhoid Mary, but still carriers and, not having the same effects, if you will. They were asymptomatic, right?
Right. Well, what happens is we see when elderly people get this disease, this virus, we see the deaths are happening in that age group. And so we worry about different things with them. So we worry about them contracting the virus, but then we worry about death because of other underlying diseases, because of AIDS, things of that sort. But that chunk in the middle, I think, is the most kind of significant chunk to look at, that kind of 25 to 44-year-old age group. Because what happens is in the 25 to 44-year-old, many of those people are still working. Mm-hmm. And they have to work because they have families, they have to take care of, elderly parents, they have to take care of the children. And so that group of people, for many of them, still have to work. And so when they get this virus, sometimes a healthy immune system can overpower itself and over-respond. And I think that's why we started to see some hospitalizations in that 25 to 44-year-old age group, because there's either a hyper-response of the immune system, or there's other factors just in day-to-day life that can also weaken the immune system. So poor diet, lack of exercise, lack of rest, proper rest, and just overall taking care of your body, because you are doing so many other things. And so there are factors that we have to worry about and think about in that middle age range, the middle range group.
I think that's definitely interesting to explore. So we're talking about that middle age. You said 24 to 44?
Mm-hmm.
So it's, it's not as if that they were unhealthy, like you were saying, but that the immune system kicked into overdrive?
Yes.
Can you tell us a little bit more about that?
So we can do that. And so you can have a hyper response of your immune system where it almost fights itself. And so there have been some cases where that happened in otherwise young, healthy adults. The other side of that is you can have these young, healthy adults that have no symptoms and don't even know if they've had the virus or not, right? And so I have been healthy throughout this whole time. I've been taking extra precautions. I've been very careful about who I've been around and social distancing and all of these things. But I could have had the virus. You could have had the virus, and we've not had that the signs and symptoms of it because our immune system fought it off, dealt with it as our immune system is designed to do and does every day with all kinds of things we're exposed to. But it takes care of it, and we never know about it. That's what it's supposed to do, right? But you can have that immune system that kicks into overdrive and almost turns on the host. It turns on you and can then put you into a very precarious state, and hospitalizations happen.
You say you've been healthy. My husband is convinced that I had it already because there was a period in December where I was not feeling well, all of that. And like you said, I did get over it. You know, I didn't need to take anything, and my body definitely fought it. But I will be interested when it's time to do those antibody tests to find out, you know, who's had it and, you know, who maybe was diagnosed with a respiratory infection and what they really had with COVID that we find out later.
I think we'll be surprised how many people will have antibodies to COVID-19 and never even knew that they were infected. And so I think that's one of the issues with reporting of the virus. It's hard to tell everyone who's had it.
So even when it comes, let's say people that had it and maybe they, you know, were like me, they just stayed home, got better, you know. So when we're talking about just the reporting even on a federal level, can you clear something up? I feel like I'm getting conflicting information even from pundits. So does the CDC track racial demographic information when they're collecting the test results and things, when they're processing test results?
I think it depends on where it comes from. So think about how the CDC gets information. So the CDC gets information on the national statistics from states. It is only as good as the information that the states provide. The states get information from labs. And so you have several layers that's going to collect this information. And so I don't think that each state, each lab is collecting the same information. And if they are collecting it, they may not be reporting the same information. So in Arkansas, we're reporting, if you think about the governor's briefings, for a while he would report number of cases in whites, or really it was Director Smith, the number of cases in white patients, black patients, and other, right? So that was a huge bucket lumped in of several different other races and ethnicities in that other category. And so we have been collecting racial data from pretty much the beginning. But not every state, not every lab is collecting and or reporting that information. And so the CDC's kind of health and the CDC's racial and ethnic group reporting is still emerging. It is not perfect. It is not complete. And I'll repeat that. It's not complete data. And so we don't know truly nationwide what we look like when it relates to COVID-19 because we do not have a national repository of information that's the same from all reporting sources. And that's the issue with, and that's a whole another conversation, a bigger issue talking about how a centralized reporting system for our health data. When we all have different reporting systems, we all have different data systems that we use and different data that we're giving to our national organizations, it is very hard for it to be complete. In Arkansas, I think we're doing a better job of watching the numbers and watching the true racial and ethnic background. But the other part of that is, though, Amber, is are we making sure we're getting the same information from all the labs? And so
because the private labs play a part in that too, right?
That's right, absolutely. So the Quest labs and the private labs absolutely play a part because we had to use them because we're overwhelmed with capacity from the Department of Health standpoint and from a UAMS standpoint as the state's academic medical center. And so we had to employ and use those labs that are private labs, but again, they're private. So you almost can't, you have to have a federal mandate or a state mandate that says you will give us this information. The other part of that, though, there's another layer. The labs, the private labs, are getting information from testing centers, testing sites, physicians' offices. So again, it has to be that everybody's reporting the same data on all levels.
So on the state level, so on the larger level, I'm just making sure I understand, we're acknowledging that the CDC isn't perfect and that everyone, like each state, if you will, reports or gathers the information differently, and thus can make it hard to track at the federal level.
Mm-hmm.
And then at the state level, it is also multi-layered because we have private and public, laboratories trying to collect this information, and even they're not all getting the same. So there does not have do you have one?
Say that last part again for me.
So Arkansas does not have a mandate for all labs to report the same thing? Is that what you're saying?
Yes, so I'm saying so the private labs are not, they are regulated by the state, but they're not told kind of what to do by the state, right? So they report, the state can ask for information that those labs give them information, but they may not be reporting all of that data on all of the patients, especially early on.
So when we think about, so I was talking with a colleague who was kind of looking over just our numbers altogether, as far as the number of cases and testing and how many people we had tested and things like that, and was concerned maybe that we had not tested enough people and was comparing us to maybe states around us, right? Mm-hmm. And when we look at a state like Louisiana, while they may be close as far as population overall, they're also very different because they have several major cities, right? Mm-hmm. They have Baton Rouge, they have New Orleans, they have all of these cities in Louisiana, whereas in Arkansas, you have Little Rock, and, you can consider, Northwest a more emerging, kind of major city, but we pretty much have Little Rock, right? And that's even where our largest academic institution is. So as far as us testing the state of Arkansas, what does that look like for our numbers? Because we have these options such as the online screening, right, or the phone. But if I call in with symptoms, and let's say the doctor, sees me and, that's the point of being a physician and developing that professional gestalt, right? I know that if I see these 5 things, I can pretty much guarantee you this is what it is, even if I haven't given you an official test, right? Mm-hmm. Mm-hmm. So if I know this was this, and I tell you to quarantine yourself and, not to be around anyone, that then does not go in that number, if you will, of reported cases, right? Because there's not an actual test, which again plays into, how accurate are our numbers? How do we really know, how sick Arkansas is or is not, based on, these methods that we're employing to kind of, mitigate, if you will, or alleviate the populations that may not be able to make it to Little Rock. And even with the fact that we may have some mobile testing, but if I'm doing the telehealth screenings and things like that, and the doctor is pretty sure I have it, but that doesn't go in the numbers, then what happens to that data? Is that just information that we're missing out on?
So I think that, first of all, that's an excellent question, and there are several layers to that question. So the first part is we don't have enough tests to test the entire state. We know that. So what has happened is there have been parameters put in place for who should be tested. And when you're looking at a case of limited supply, limited quantity, who should be tested, you got to make some decisions, right? So we looked at testing initially. We did, those that had symptoms, we looked at contacts, those that traveled from out of the country or from states that we knew were heavily impacted by COVID-19. So we tried to do that first, right? And so that didn't work. We tried to contain it first, and that didn't work. So then we said, okay, we now need to increase what we're doing. So we started testing people that have symptoms, that have known contacts in the state, that have a fever, those kinds of things, to start catching and finding those people that are infected with the virus. People, though, who did not have symptoms or maybe had symptoms but didn't have a fever were told to self-quarantine. Mm-hmm. And so those people still haven't been tested. The other thing is we talked a little bit earlier about those people who never truly had symptoms and maybe just quarantined because we were asked to do that and not be out and about around people. And so those people were never tested and probably never had a reason to ask to be tested. So the numbers that we have are the obvious numbers. those people that have been ill, those people that have been hospitalized, those people that we absolutely know needed to be tested. But I don't think we will understand really how sick Arkansas was or is until we have antibody testing. Then we can widely cover everybody and understand the true impact of COVID-19 on our state. Nobody knows the true impact of COVID-19 on Arkansas or worldwide for that matter, because there are so many moving targets. And remember, this is a virus. And so viruses will infect the body, and if your immune system works the proper way, it rids the body of that virus. And so many times people will have a mild case of a virus and it goes away and we don't really ever know what it was. So we are not sure of the numbers. The only numbers we can analyze and talk about are those that are reported to us from those people who are sick or had a reason to be tested. And so that is one of the things that puts us at a disadvantage when you don't have adequate supplies or labs or whatever you need, sites to test everyone in the state.
Well, I know we can definitely look at it and saying that we don't know how sick we are, but when you were just talking, on the flip side, I think it could be exciting that we don't know how healthy we are. Mm-hmm. Mm-hmm. What we do know is, like you said, we know for sure the number of deaths. Mm-hmm. We know for sure who has been hospitalized. We know the demographics of what it looks like of those people hospitalized. But we don't know the numbers of those people, like you said, that have recovered. They maybe didn't have symptoms. Their body fought it off. They just thought they had a cold. And I think that one that, of course, speaks to the resiliency of just the human body and the way it, when it functions the way it's supposed to. But two, maybe the outlook could even be different. That while these numbers, it may take us a while, if you will, to get more accurate information. Or so I think that, we just they're still publishing papers on the SARS pandemic, and just kind of figuring out when it started, and they were able to go back and look at it in hindsight. But even if we're looking at just right now, I think it could be very exciting that what we can say is that we could even be healthier than we think we are based on who could have recovered, maybe they didn't know they recovered, or they self-quarantined and didn't infect, the next person. So that's an upside.
But I think that's an important upside, right? And so for people that have not had any symptoms, have not, I don't think I've been exposed to COVID. I think I've been healthy and well. That's a reason to continue to eat properly, to get good hydration, to exercise, to keep my body healthy, right? And so I think the positive side to that is if we did have it, right, and you recover, you're doing something right. So you're feeding your body the right thing. You're hydrating your body. You're keeping it healthy. You're exercising. You're getting rest and proper sleep. And so I think that it's important for people to continue to do those healthy daily activities, even though our schedules are a little bit messed up right now. It's uncertain and it feels crazy and weird, but it's important to keep doing those things and to keep our bodies healthy and to keep eating fresh fruits and vegetables and to keep eating, regularly and eating nutritious foods, because in times like this when you don't have a true schedule, it's easy to get off with snacks and sugar-laced and salt-laced foods, to get off your exercise routine, right? My gym is closed right now, so I'm doing virtual workouts in the morning at 5 o'clock. But it's important to keep some sense of normalcy, not only for your physical health, but for your mental health.
Agreed. Well, we have lots more coming up. Dr. Rice, thank you for being here with us this morning. I have several more questions. Right now we're going to prepare to, we're going to go to break and hear a couple of messages. And then when we come back, we will have more with our COVID facts and facts. Again, I'm your host, Amber Booth-McCoy. We have with us the amazing Dr. Lanita White, and we will be back soon. Hope you join us.
Profile America, Friday, May 1st. By presidential proclamation, this month recognizes one of the nation's fastest growing population groups, those of Asian and Pacific American heritage. The observance began in 1978 with a joint congressional resolution honoring the arrival of the first Japanese immigrants in the 1840s and the completion of the Transcontinental Railroad in 1870 with the help of Chinese immigrants. The occasion was extended to the entire month in 1990. Now, nearly 22 million people in America are of full or partial Asian or Pacific American heritage, over 6.7% of the total population. Hawaii is the state where Asians and Pacific Islanders make up the highest proportion of the total population at almost 64%. You can find more facts about America's people, places, and economy from the American Community Survey at census.gov.
Wonder if you should get tested for colorectal cancer? Well, it's the second leading cancer killer in the U.S., and screening helps prevent it. So if you're 50 or older, it's time. Even if it doesn't run in your family, most often, colorectal cancer occurs in people with no family history. And it doesn't always cause symptoms, especially early on, so don't wait for symptoms to get tested. Screening helps prevent the disease by finding precancerous polyps so they can be removed. Remove the polyp, prevent the cancer. Screening also helps find colorectal cancer early when treatment works best. You might be thinking, oh no, not that test. But here's the thing, you have options. There's more than one screening test. Talk to your doctor to find the one that's right for you. No more excuses. If you're over 50, get tested, because colorectal cancer screening really does save lives. A message from HHS and CDC's Screen for Life campaign.
And welcome back to COVID Chats and Facts. I am your host, Amber Booth-McCoy, the Senior Diversity Specialist in the UAMS Division for Diversity, Equity, and Inclusion. And if you missed the first half of this conversation with the amazing Dr. Lanita White, then you will have to catch up later because we have more to talk about and more to discuss. Right, Dr. White?
That's right.
So next question is, when we are talking about, or I sat on a panel once, and the moderator said something to me that was profound. She said that when white America gets a cold, Black America gets the flu. Mm-hmm. And that's kind of what we're looking at right now, right? Mm-hmm. And we are talking about even the hospitalizations or who is hospitalized. Then, yes, the numbers of people hospitalized may look different or higher in concentration of communities of color, particularly African Americans, but for many different reasons. It's not just because we're Black, because COVID doesn't know we're Black, right? COVID doesn't know I'm Black, right?
Yes. COVID did not look at the census.
COVID did not look at the census, has no idea that I stay in Southwest, any of that. So,
right.
If it is, again, affecting us in many different ways, what does the disease look like in even just the African American community?
Yes, this is a very interesting question because the impact on the African American community in general with COVID-19 is really related to underlying health issues. And so when I'm talking strictly from a health issue standpoint, now there's a whole different conversation related to social determinants of health, so economic access, all those. That's a whole nother ball. But just pulling out that health care and healthcare access issue. So when you look at that, many people have correlated COVID-19 to flu, and they say, it's similar to flu or it's not similar to flu. Well, let's just take a walk with me then look at flu in the African American community.
I will always take a walk with you.
Thank you so much. And so when we think about it, the number one killer in America has been for a long time cardiovascular disease. Cardiovascular disease is the number one killer of Americans, period, especially also Black Americans. And when we look at COVID is a close second, and some days, depending on the data that you're looking at, COVID is number one. So if you look at the number of deaths per day, COVID is trumping cardiovascular disease. Yeah. So when you look at that and we say, okay, we're going to parallel this to flu. So when I look at flu in African-American people, African-Americans with the flu also tend to get pneumonia. Not just get the flu, they tend to get pneumonia. And then if you look at the impact on flu and those patients that have cardiovascular disease, afterwards, there's a 30% increase in those people that have flu and having heart disease, having a hospitalization, having a heart attack, having a rehospitalization because of a heart attack. There's an 8-fold increase in those same patients that got flu and recovered being readmitted into the hospital 3-4 days later with a stroke. And so those underlying diseases can be triggered, and we then have residual issues that happen even after just the flu. And so if we look at COVID-19 and we say it's similar to flu, then we're starting to see that some of those other underlying conditions that are traditionally killers of Americans are happening in our society as well. And we are starting to see that there is residual impact of having this virus on other diseases. And so when we started looking at the people who were at risk for COVID-19, we looked at a lot of different things, right? We looked at people who had diabetes, who had heart disease, who had COPD, chronic kidney disease, people that had chronic lung disease, and then those who were immunocompromised. What we're seeing is the number one comorbidity in COVID-19 is diabetes. Number 2 is heart disease. So when you're looking at people,
if I may, Dr. White, for those of us that are not as amazing as you and/or do not work in a healthcare institution like me, will you break down the word comorbidity for us?
Absolutely, I absolutely will. And I'm supposed to know better than that, right? So comorbidities, right? So if you have hypertension and diabetes, high blood pressure and diabetes, you have a comorbidity. It's diseases that you have that can increase your risk of death, right? Mm-hmm. And so if you've got diabetes or, grandma, so I got sugar and pressure. You got sugar and pressure, that's what we're talking about. If you have lung disease, so if you have COPD, you have asthma, you have those kinds of lung diseases where you either have to take inhalers or you have issues from time to time with breathing that have been diagnosed, that's chronic lung disease. If you have, when I say heart disease, I'm talking hypertension, I'm talking high cholesterol. Even having diabetes puts you at risk and in a category of having heart disease. And so when you think about all of those things, so diabetes, hypertension or high blood pressure, heart failure, lung disease, all of these diseases that can cause an increased risk of death, comorbid states. So morbid meaning death. Comorbidities is what we're talking about. Even obesity, all kinds of things. You kind of, look at your laundry list of diseases. And when you have that, certain ones increase your risk of triggering another event if you have it. And I'm just basing that on flu. So if you've got a patient that gets flu and they've got diabetes, the person that has flu and they have heart failure, they're at risk even after recovering from the flu. They're at risk for a heart attack. They're at risk for a stroke. It is affected differently because of those other diseases. And so when we see that and you have multiple of those underlying diseases, multiple of those chronic diseases as we call it, so things you have to treat forever or for a long time or for the rest of your lifespan, we have to be careful and worry about that. And why that's significant in the African American community is because we are affected disproportionately by those diseases. There are a number of reasons why. Most of them are not genetic.
Many of them that's a whole different conversation.
Right. It has to do with absolutely. It has to do with lifestyle, access to food, access to care, access. It has to do with those things. And so if you're eating most of your foods or you're eating foods that are out of a can because that's what you have access to, that affects your health. right? If you are in a place that maybe doesn't have the best breathing conditions, or you've got mold, or you've got other things that can cause breathing problems, that can affect your health. It can cause lung disease. And so if you're smoking, it can cause lung disease. If we are drinking, it can cause kidney disease. So we have all of these other layers that we have to address in our community that sometimes we are not able to address. And those can play a big factor on your overall health. And when you add another virus on that is aggressive, as COVID-19 can be, it adds another layer.
So I have a question for you, because since the global pandemic, apparently all of my friends are now epidemiologists and scientists. All of my Facebook friends have now gone to the University of Facebook, and they have so much information. So my question is about if you were classifying death. So like you said, let's say that I have that I know what these symptoms look like, right? It's like it looks like a duck, it walks like a duck. Testing someone is for the confirmation of, but not to, like the original differential, if you will, or me knowing that this is COVID without testing it, because I know what these symptoms look like, because that's what your physician, your clinicians are supposed to be able to do. And the testing, if you will, is just confirmation, right?
Mm-hmm. Mm-hmm.
Now, if someone is, let's say, in the hospital, they're presenting with these symptoms. We have not tested them yet, and unfortunately, they passed prior to us getting an official test. Mm-hmm. And the CDC has released guidelines. Correct me if I'm wrong. It says, even if you haven't tested them, if they had the symptoms, you mark it as COVID. Mm-hmm. And like I said, my Facebook epidemiologist friends and everyone is saying that's not fair. And like you're saying, if I have these comorbidities, let's say that I do have heart disease and I do have diabetes and I have COVID and I pass away, which one are you saying which one are they going to say that I died from? Did I die from the heart disease? Did I die from COVID? Which one?
That's an interesting question, because I was talking with someone about this the other day. So when a person dies, the medical examiner or the physician that caused the death calls it and says, this person truly has expired. They mark the cause. They're asked to mark the cause of death. In this environment, we just talked about the effects of comorbidities, these other diseases, on COVID on a person and how that can affect a person, right? The true answer is we don't know. There are many people who have died during this time, so between, really January and now, who their cause of death may have been diabetes, complications from diabetes, heart attack, lung disease, especially lung disease, because that's what we could see. We didn't test them for coronavirus, and we were not able to identify truly, or not comfortable with identifying that being the cause. But that virus could have absolutely triggered the cascade of events that caused them to die. And so I also think with our death reporting, we are absolutely missing people, because there may have been other events and other diseases that were triggered, and those heart attacks, strokes, things of that sort were triggered because of COVID-19, and it wasn't caught. And so we don't typically test people after they die. And so there will be people, I can assure you, there are people who died as a result of COVID-19, but it was COVID-19 with, right? So COVID-19 with a stroke, COVID-19 with a heart attack, but we don't have a way to quantify which came first, the chicken or the egg.
Ooh, you arming me for these Facebook battles.
I too have a lot of Facebook newly minted epidemiologists, and I just say, "Oh, bless your heart," and keep going.
Because it assisted me in cleaning up my friend list, because I have started unfriending people.
Yes. And I think for us, we have to be very careful about what we allow on our Facebook pages and what we share, because people look to you as the person who must know. Right? She's got to be in the know. This has got to be right. And people are most people are hungry for information because we want to understand this. We want to know what's going on. We want to have some facts and answers. But people can get caught up, especially now with a little bit of free time on your hand. People can get caught up in social media doctors. And sometimes that muddies the water when someone like you or someone like me or any of our other colleagues try to put the right information out on social media. It confuses people on what to listen to. And people want to have an answer. So if an answer sounds good and it sounds like it could work, we had some interesting recommendations last week. If it sounds like it could work, then maybe I should. And so I think we have to steer people in the right direction and steer them to facts and data.
I think the key word that you have said now twice is facts. Facts and data.
Facts and data.
Anytime I get to be included in a list that includes you and our other colleagues, then that's a good day for me. So you tell my mama I am winning today.
Right. I love it.
When it comes to all of the numbers that we're talking about, even the upside that we may be less sick, if you will, is being done in the state. What are the statewide efforts or organizations that you know of, and especially amazing organizations like AMDPA? If you can, one, tell us what AMDPA stands for, because we use acronyms so much that we, sometimes forget to explain what those things are. So if you could tell us about AMDPA and then maybe some of the efforts that are happening across the state.
Sure, absolutely. So AMDPA is the Arkansas Medical, Dental, and Pharmaceutical Association. So AMDPA, and it's a professional association of minority physicians, pharmacists, and dentists here in Little Rock in Arkansas. And we work throughout the state. So we are a statewide organization. And it's a pretty old organization. We are 127 years old now. And so very proud of that. But it is a wonderfully continuously operating coalition of terminal degree healthcare providers. And so we have several goals as in AMDPA, one of which, and our major one, is to reduce and ultimately get rid of health disparities in Arkansas. So those things that create differences in our levels of health. So health disparities, that's what that means. And so these are the things that can create the differences in our health across ages, across ethnicities, across zip codes, across education levels, across access levels. We want to eradicate that and get rid of it so that everyone has the opportunity for their best health. The other thing that we do is try to increase diversity in our medical community, so in that pipeline. And so increasing our diversity in our colleges of medicine, colleges of pharmacy, college of dentistry, the physician assistance program, wherever we can get and spark that interest of minority students in careers in healthcare is where we want to focus, because we know if the healthcare workforce is more diverse, we have a healthier population. And then we try to provide cutting-edge and relevant information to our members. And so, again, our members are healthcare providers that are taking care of patients, and we try to make sure that we provide them with cutting-edge, state-of-the-art, forward-thinking information for their practices so that they can ultimately take care of patients. And then lastly, what we've been doing a lot of since March 8th is advocacy for and looking at public policy for not only our members but their patients as well. And so we do a lot of outreach and awareness as a part of that arm of our organization. So that's a little bit about AMDPA. And then I have to know all that stuff as the president. That's what I've been doing.
Just humbly left that part out.
But the interesting thing is there's a lot going on. And so March 8th, my phone started ringing, my text started going off, and people contacting me about what are we going to do. And so what I've experienced here in Arkansas is the ability to partner with other like-minded organizations. And so one of the things that we did is we created the COVID-19 Minority Stakeholders Coalition. And what we've done is we've brought in all of those stakeholders. So we, as AMDPA, we're focused on health. My main focus is my members and making sure they have the tools that they need to navigate through this COVID-19 pandemic so that they can help their patients and families. But we had to also bring in those partners that are collecting data, those partners that are working with the community and outward-facing, those partners that are working with mayors and local governments. And so to get us all at the table to talk about the different pieces that come into play when you're dealing with a global pandemic that has now hit our state and has kind of been dropped on our table. And so one of the things we've done is to partner with other organizations to be able to talk about these issues, problem solve, most important, problem solve these issues and figure out solutions. And so we're working with the Department of Health. We're working with the Arkansas Minority Health Commission. We're absolutely working with the UAMS Division of Diversity, Equity, and Inclusion. Yes. We're working with the medical school in Jonesboro. We are working with the Black Mayors Association. We're working with the legislators, the Legislative Black Caucus, to make sure that we are really covering those issues that affect minority communities, but those issues that also affect all communities. And so we are not exclusive. We put our attention on minority communities because we want to make sure that we have equality, but we realize that these same factors affect all people, all humans in general. And so that has been one of the things that we have done to partner with them. And as a part of that coalition, we've done some town halls. We did a town hall focused in Jefferson County about 3 weeks ago. We have one coming up next week that's going to focus on the Delta part of the state, the Delta region of the state, to really talk about these issues and bring resources to that part of the state. We also,
is that for everyone? Can anyone log on to that town hall?
Absolutely. That is for everyone. Anyone can tune in. You can look on our AMDPA Facebook page. We put all of that information there. We ask people to tune in and listen. It's a Zoom webinar, so you can tune in. You're going to be on mute and listen in and get all the information that we have there. You also have an opportunity to text in your questions so that we can have our panelists to answer those questions, which are, I think, the best parts of our town halls are the questions that come from the listeners. And then the other thing I'll tell you, we have some other resources in the state and the city. So UAMS has the drive-through testing sites here at UAMS. You can drive through. It's signs everywhere where you can get tested for COVID-19. UAMS also has the mobile unit that has been traveling the state and going to different areas. I think this week tomorrow they're going to be at the Southwest Community Center to do testing there. We also
in Little Rock.
In Little Rock, yes, in Little Rock. Okay. We also have a community mask project where we are having masks made for the community. And the thing that I love about this project, and we are partnering with the Medina Institute. Yes, which is a local mosque here in town. We are partnering with the Little Rock chapter of the Links Incorporated and also the Panhellenic Council, which both of our sororities belong to.
Yes,
and so we are partnering with them on a mask project. But the wonderful thing about this mask project is it's also providing jobs, because we have women and men who have lost their jobs due to COVID-19, and they're able to recover some of their income by making masks to help the community. And so we are so excited about that project, and we're also collecting donations for that to help to pay it forward. And so we want to make sure that we can be a part of putting a mask on every single person here in the state. And our mask project is for the most part Central Arkansas, so the Little Rock and surrounding areas. But I know other parts of the states also have mask projects going on as well. And the last thing I'll tell you is that, you can always get sound and up-to-date information from our Facebook page. And one of the things that we do is we load the governor's daily briefing on our Facebook page every day, even on the weekends, because we want people to have the most current and up-to-date information and be able to find it in an easy way.
Definitely. I absolutely love that project. At this point, My husband is used to seeing that charge in our bank statement because I just go by the mask constantly, because definitely I want to support. And I absolutely love the collaboration, working with, of course, you and other organizations in the Division for Diversity, Equity, and Inclusion, because many hands make light work, as I always say. And the other part of that is that great minds don't think alike. And so there are many voices and people that you can have at the table trying to figure out these problems, the best outcomes there are for the maximum number of people. So that's exciting.
Right.
When we're talking about even the resources, I want to make sure you said that we can find out more about the town hall on the AMDPA Facebook page. Is there an Instagram page or a Twitter or any of that?
Well, there are, but I don't know how to work those things. I just stick to Facebook. I stay in my lane. And so there is an Instagram page that our intern manages, but I don't know how to work those things. But so I say my lane is Facebook.
And then listeners, you're always welcome to follow the UAMS Division for Diversity, Equity, and Inclusion Facebook page, Instagram, and Twitter. We often share information from those same partners. The Arkansas Minority Health Commission puts out awesome information very regularly, and we try to share that as often as possible.
Yes.
The information as far as what UAMS is doing, if you're looking for maybe screenings or you're wanting to have a telehealth screening, you can call first, and that number is 1-800-632-4502. Again, that's 1-800-632-4502. You can also go to uamshealth.com, and on the first page you will see COVID-19 updates, and you can click and find all the new information that is updated very, very regularly, so that you can see the information that we're putting out about our institutions, the visitation policies, anything that may have changed that we have going on, the dates and times of those mobile or the drive-through sites. And again, before we get ready to get out of here, I just want to, of course, thank you so much for being here. I, of course, love talking with you, whether in email, text message, or even during a COVID Chats and Facts, because you are a devastating diva. So shout out to Delta Sigma. You're on my list, right? You're on my list of favorites. And listeners, if you will tune in with us next week as well, we are going to be here every Friday at 11 o'clock. Same bad time, same bad channel. And next week, we're going to be discussing pregnancy during COVID. Doesn't that sound like interesting, like fun information?
Absolutely.
Because it can seem daunting or scary, and I'm hoping that we're able to alleviate some of that fear when we bring in the experts that are actually still delivering during this time. When it comes to just finding more information about those mobile sites, like I said, I know that we have been to Mariana, Forest City, and a couple other places. Other than UAMS, are you familiar with any mobile testing that's going on with any other organizations?
Yes, so there's one that they're trying to get started in the northeast corner, in Jonesboro, and there have been some discussions with some other entities to get their mobile units up and going. And I think we'll start to get some more information out soon about those opening up. But right now, UAMS is the one that we know that is functioning and going out to centers, but there should be more information soon. And as soon as I hear about that, I will get that info to you so you can share it with your listeners, definitely.
And you touched on this just a little earlier when we were talking about mental health during this time. So this, to me, while it is a global pandemic, I have said several times that I'm excited because it feels like we're in a new world, which means that there's a new cultural landscape. And we get to shape that together. So the things that we felt like maybe were inequitable or wrong or things that needed reshifting, I feel like we have the opportunity to do that. So that's an exciting place for a diversity specialist, anyway, to be and to be idealistic about that. So while we are making sure that you are one step ahead, because you said you are exercising at home during these Zoom, like I get taken by Zoom or something like that.
Yes, by Zoom, yes.
Mm-hmm. And see, I didn't do that prior to the pandemic, so just starting to exercise during the pandemic would probably just make my body try to really figure out what's going on. But the mental health aspect of just making sure, last week we talked with Dr. Haynes, and she informed us that it's okay to not be okay.
Yes.
And that it's okay to take some time, and that we just want to remember to have grace and be patient with each other as we allow each other to navigate and figure this new world out together. Mm-hmm. We keep hearing this word unprecedented, but it really is. This is a new time for everyone, and what that looks like for everyone is different.
That's right.
Exploring that together, like I said, it is exciting. It can be scary, but I also think that means that each of us has the opportunity and maybe even the responsibility to be the authors and creators of this new world.
That's right.
As we get ready to get out of here, again, I just wanted to thank you, Dr. White, for being here, making sure that you can always look up the information, and we'll be here every Friday. You can check out the UAMS Division for Diversity, Equity, and Inclusion. The website is www.ddei.umss.edu. And we will be here again every Friday for COVID Chats and Facts. Next week, we're going to talk about pregnancy during this time. And as we are going through this together, remember that we may be alone, but we are alone together. So remember to be kind, be inclusive, and be well. I am your host, Amber Booth-McCoy. We'll see you next week.
Thank you.
Thanks for having me. Bye-bye.